Good afternoon. I'm Tomiko Brown-Nagin, Dean of the Radcliffe Institute for Advanced Study at Harvard University. It's my pleasure to welcome you to this afternoon's program on obesity, COVID-19, and systemic racism. This discussion continues our series of public programs offered as a part of the Presidential Initiative on Harvard and the Legacy of Slavery, which President Larry Bacow launched last year. The initiative is anchored here at the Radcliffe Institute, and we're committed to providing opportunities like this one to examine the complex histories that continue to shape our nation. You can learn more about the initiative at legacyofslavery.radcliffe.harvard.edu. Today, we examine these histories through a contemporary lens. In the past several months, COVID-19 has taken more than 1 million lives around the world. Here in the United States, it has sickened nearly 9 million and killed some 225,000. But it has not affected all communities equally, as we learned over the course of our summer programs on COVID and health equity, now available online. Data collection presents an ongoing challenge, but experts agree that the pandemic has disproportionately impacted communities of color. According to the Atlantic's COVID tracking project, available figures suggest African Americans are dying from COVID-19 at more than twice the rate of white Americans. And death rates among Hispanic and Indigenous Americans are roughly 1.5 times higher than for white Americans. The pandemic has underscored racial inequities in disease burden, health outcomes, and access to care. But these disparities are not new. Well before COVID-19, Black Americans faced higher rates of chronic illnesses and infant and maternal mortality, as well as shorter life expectancy. African Americans are also more likely than non-Hispanic whites to be uninsured and more likely to forego health care due to cost. These disparities reflect the complex interplay of many social determinants of health. They're also a concrete example of the enduring legacy of slavery in our nation. As Sabrina Strings wrote in a much discussed New York Times op-ed earlier this year, slavery set in motion Black people's diminished access to healthy foods, safe working conditions, medical treatment, and a host of other social inequities that negatively impact health. This afternoon, as we examine the enduring impacts of slavery and systemic racism on the health of Black people and communities of color, I'm delighted to have Sabrina Strings and our own Sara Bleich here to guide us. Sara Bleich is a renowned expert on the prevention of obesity and diet-related diseases. She is a Carol K. Pforzheimer Professor and the Director of the Social Sciences Program here at Radcliffe, as well as a professor of public health policy at Harvard's T.H. Chan School of Public Health and a faculty member at Harvard's Kennedy School. Sara is the recipient of numerous awards, and she served as a White House Fellow and Senior Policy Advisor in the Obama administration. Sabrina Strings is an Associate Professor of Sociology at the University of California, Irvine. Sabrina's award-winning scholarship examines race, gender, and the sociology of media and of medicine. Her recent book, Fearing the Black Body, The Racial Origins of Fat Phobia, won the American Sociological Association's 2020 Body and Embodiment Best Publication Award. And finally, to start the Q&A portion of our program, we'll be joined by Motunrayo Tosinoni, a first-year PhD student in health policy at the Harvard Chan School, and Brent Clark, a third-year PhD student in sociology at UC Irvine. Thank you to Sara, Sabrina, Motunrayo, and Brent for joining us this afternoon. Before we begin, I want to take a moment to acknowledge the members of the Radcliffe Institute Leadership Society and all our annual donors. Your generosity keeps Radcliffe programming free and open to the public, and we thank you. Now for some logistics. Sabrina will start the discussion in just a moment, followed by Sara. Motunrayo and Brent will kick off the Q&A with their own questions for Sara and Sabrina, after which we'll move to audience questions. You can use the Q&A feature on Zoom to submit your questions at any point during the program. We only ask that you keep your questions brief. With that, let's begin. Sabrina, the floor is yours.
Thank you so much, Dean Brown-Nagin, and thank you to the organizers of this event. So it's my pleasure to give a talk on this timely and important topic. The title of my talk is The Logic of Dismembered Black Inclusion, the Problem of Medical Research. So if you've been paying attention to the news, you will notice that there has been a recent resurgence in studies linking obesity to the severe COVID-19 complications, as well as to rates of COVID mortality. And yet there's something very important to keep in mind when we're considering the relationship between COVID-19 and obesity, specifically when we talk about health disparities between Black and white populations. You will notice here that data from the CDC show Black Americans have a so-called obesity rate of 38%, whereas white Americans have an obesity rate, purportedly, of 30%. You will notice that this is a mere 8 percentage point disparity in rates of obesity. However, when we look at the toll of COVID-19, what we are finding is that Black Americans are experiencing rates of death that are 3.2 times that of white Americans. Researchers have yet to explain how an 8 percentage point disparity in rates of obesity is somehow responsible for hundreds of percentage points of an increase in rates of mortality for Black Americans. When I took up this issue in my New York Times op-ed earlier this year, I explained that the problem is not obesity, the problem is slavery. That is, the legacy of slavery is such that it inaugurated a series of circumstances for Black Americans that left us with, if we are lucky, if our ancestors were lucky, the basic necessities for life, right? So that did not include routine health care, access to healthy foods, clean drinking water, many of the other privileges of being free. All of these instances of lack of resources, right, contributed to Black Americans experiencing, if they are lucky, again, bare life under the conditions of slavery. And if they were unlucky, obviously, death. Now, that analysis still stands. Recent research on obesity and COVID has not in any way helped us to explain how disparities between Black and white rates of obesity are contributing to this enormous rates of difference with COVID fatalities. But today I'm going to turn to a different point. Instead of simply considering what led us to this particular moment, I want to think about what are some of the consequences of the legacy of slavery, particularly as it pertains to the field of medicine. When we're thinking about our aims of reducing these disparities in COVID mortalities, and also just in improving access to treatments for Black Americans. I will argue that as a result of the legacy of slavery, even within the medical field, that Black Americans could expect that their body parts, their dismembered flesh, their tissues, their cells, could be used for medical research advancement, but not their whole biographies. And because of that, because of the orientation of the medical field to the Black body as in service of medicine, and in medicine and in service of white populations, we're going to find that it's going to be very difficult for us to address these disparities in a meaningful way. So I'm going to give you this analysis in 2 acts. First, we know that historically, Black people were integral to medical research. What we have here is an image of Marion Sims to the right of the screen with his arms folded in front of his chest. He's the father of the modern gynecology. And he was able to make considerable advancements within the field of gynecology by performing experiments on slave women. You can also see depicted in this image Anarcha, one of the slaves that Marion Sims routinely performed experiments on. After performing dozens of experiments that were otherwise unnecessary, except for that he was hoping to advance his understanding of female reproductive organs, Marion Sims was able to create the speculum, which is now still used in gynecological practice. And so we can understand how the use of the Black female body in this instance helped medical science. And this is not the only instance. Probably the most famous instance is the use of so-called HeLa cells. Henrietta Lacks came to Johns Hopkins Medical Center sometime around 1950 because of an aggressive form of cancer. What then happened was that doctors were not able to help her in any way. However, they did mine her body for the cells and then use these very aggressive cells in their medical research. HeLa cells are still used today, even in COVID-19 research. So they are used around the world for greater understanding of myriad forms of diseases. But of course, they were not used in any way that might have been beneficial to her or her family, nor were her cells taken with her consent. We can contrast this with the reality that Black people today are rarely used in clinical research or in clinical trials, including COVID trials. Scientific American reported that although African Americans comprise approximately 13% of the population, and although people of color comprise 40% of the population, people of color are routinely underrepresented in studies, sometimes representing as little as 10% of clinical research. Again, the goal of clinical research is to help us figure out treatments to help populations. And notice that when that is the goal, overwhelmingly, the people involved are white. This is also true for COVID trials, which again, although Black people comprise 13% of the American population, we only comprise approximately 5% of COVID studies. And this is not by chance. This is part of what I'm calling the logic of Black dismemberment within the medical field. That is, to the extent that the field of medicine, which was also professionalized around about the same time that slavery was being formally dismantled, nevertheless invested in the same relationships. That is, the field of medicine is invested in using Black cells, Black body parts, Black tissues for the advancement of medical progress, but not Black whole human beings, not Black individuals, not Black biographies, such that we might be able to treat Black people and offer services to the Black community. And even though this seems like it's somehow two different instances that are disparate, they are in fact turning on the same idea that we have the right to use Black bodies in service. These are the very ideas that were generated during slavery. The Black body can be used in service of white populations and in service of shoring up the health of white individuals. But rarely is it used specifically to address the problems that exist within Black communities. So I'll conclude with this. Obesity follows the same logic. It's not immediately clear how they came up with these biomarkers for obesity in the first place. It's not even evident that it was based on any studies. It seems to have been what's called eminence-based medicine. A very powerful white man suggested we need to have these categories, and boom, they were instituted, right? In this way, Black people were excluded from the very studies that are now attempting to discipline them. BMI cannot account for the 3.2 times higher rate of COVID deaths amongst Black populations. The disparities in COVID fatalities are a legacy of slavery, but so too is our inability to understand how to best treat Black populations. And weight loss is not the answer. Thank you for your time and attention. And now I would like to invite Professor Sara Bleich to join me.
Hi, Sabrina. Thanks for that presentation. So let me start off by asking you, because your remarks were inspired by the op-ed that you wrote for the New York Times back in May, and your thesis is it's not obesity, it's slavery, is very provocative for some, I'm assuming. And so can you just give us a sense of the reactions that you received to that op-ed?
Actually, the reactions were overwhelmingly positive. Surprised by that, because that's not always the case with my research. There were several people who wrote to me, even people within the field of public health or people who were various medical doctors, who were simply excited to see that someone was taking a holistic approach, right? An historical approach, no less, because oftentimes we're given very individualizing explanations for what are clearly communal and structural problems. So overwhelmingly, people were excited. There were those detractors, but fortunately, I have the ability to simply block them and not otherwise be concerned too much about those kinds of ideas.
Thank you. So perhaps I'll jump in and offer a public health perspective. And then when I finish, we'll move on to the Q&A from Motun Rayo and Brent. So big thanks to Dean Brown-Nagin and to the Radcliffe staff for organizing this event. And it's great to share the virtual stage with Dr. Strings. I wanted to talk a little bit about obesity, COVID-19, and systemic racism from a public health perspective, and just start by underlining this problem of obesity disparities, which you've already heard a little bit about from Dean Nagin and from Dr. Strings. And so in public health, obesity is one of the most significant public health burdens. And this is because it's the second leading cause of death in the United States. And if someone has obesity, it's associated with a host of adverse health conditions. So it raises your risk for things like type 2 diabetes, for hypertension, for certain types of cancers, amongst a lot of other bad health conditions. And we're annually in the United States spending about $150 billion on obesity, and that's just in direct medical costs. It doesn't account for the indirect costs like lost productivity. And so current levels of obesity, to underline what you've already heard, it's currently affecting 4 out of 10 adults, and it's 1 out of 2 Black adults, 1 out of 2. Every other Black person in this country is obese. Amongst children, it's almost 1/4 of Black children. When we look historically, what we know is that obesity rates have tripled. And so then the question is, well, what's coming? And what this slide is showing you is the projected prevalence of childhood obesity. And so what you're looking at is obesity amongst children who are currently age 2, and it's projecting out those same children's weight when they reach the age of 35. And so take home point number 1 is just look at this trajectory. All of these children are getting bigger. Take home point number 2 is look at this call out box right here on the right. What it's telling you is that for children who are age 2 today, those white children by age 35, 53% of them are expected to be obese. For Black children, age 2 today, 69% of them are expected to be obese by the time they turn 35. Weight is a very predictable thing that we can track and expect what it's going to look like over time. What about adults? And so we just finished a study, which essentially the top line is by 2030, so less than 10 years from now, 1 out of every other adult, so 1 out of 2 adults will be obese, but that there are huge disparities by race. And so if you just focus in on that top right quadrant, what that is showing you is what's going to be the most common BMI or body mass index category in 2030. That dark brown color represents people who have severe obesity, meaning they are carrying around an additional 100 or so pounds. And so that category of severe obesity is going to be the most common category for Black Americans in less than 10 years. And so what about COVID-19 disparities? Dean Brown-Nagin has already underscored the numbers, and this is the snapshot from yesterday. And so as she said, in the United States, we have over 225,000 deaths. And while COVID is affecting all of us, it is not doing so proportionally. And so just to really underscore this point around race differences, when we look at infection rates, hospitalizations, and death rates, what we know is that if you are Black in this country compared to being white, you're twice as likely to be infected. You're almost 5 times more likely to be hospitalized, and the death rate is twice as high. But the single number I will say that has stuck with me most over the past several months is the one at the bottom right of the screen. And that tells you that if Black Americans died at the same rate as white Americans from COVID-19, more than 21,000 Black Americans would still be alive. 21,000 Black Americans because of that disparity. And so what we also know is COVID-19 has had massive impacts on the economy. And we saw in April of this past year that unemployment had spiked to 15%. That recovery has started to happen. However, the recovery from this job loss is not happening in a total equitable way. And so about 60% of job loss has recovered among whites. Less than 40% has recovered among Blacks, making the economic toll that much harder among both Black and brown populations. So what has really gotten a lot of attention recently is this link between COVID-19 and obesity. And this is what Dr. Strings was talking about. And so if you are someone who both has COVID-19 and you are obese, or you have obesity, you are twice as likely to be hospitalized, and you're 50% more likely to die. So what is driving that? And the honest answer is that we don't entirely know. What we are speculating from the evidence is that if you carry extra weight, then your body may struggle to mount an appropriate immune response to the virus. And as a result, you may poorly also respond to the vaccine. But that is not entirely clear. Here's what we do know. We know, and you heard some of this from Dr. Strings, is that there are these long-standing structural inequities that are underlining why we are seeing higher rates of COVID-19, higher rates of obesity amongst Black and brown populations. So for example, if you are Black, you are more likely to be in an essential industry. That means that you are in nursing or healthcare or in the grocery store setting. And so you're more likely to come in contact with people who are sick with COVID-19. And these essential service jobs tend to be less likely to have health insurance or life insurance. So the chances of getting the care that you need are also muted. What we also know is that there has been a broad understanding, which I would argue has been increasing lately, since the protests around the murder of George Floyd, that structural racism is a common root cause, both for COVID-19 and for obesity. And so we know that if you're a Black American, you have fewer economic and educational opportunities as compared to whites. And that what that does is confer fewer financial resources, which then increase social risks like food insecurity, housing instability, limited access to transportation, and that list sort of goes on and on. So the question then is, given this burden, given this disproportionate impact, what do we do? And the answer is there's a lot of proven policy approaches that can make a difference. Now, I want to underline the fact that a lot has already happened. So we've had a series of stimulus bills. Those have had important impacts, particularly on low-income families in the United States, but they haven't been sufficient. And what has happened now is that the latest stimulus bill, the HEROES bill, has passed twice in the House and is now stalled in the Senate and by the White House and is not expected to happen before the election. But what are some things that should happen which could make a meaningful difference? And in the interest of time, I just want to talk about the two things on the top of this slide, and then happy to talk about the others during the Q&A. So top left is expanding what's called the Supplemental Nutrition Assistance Program, which stands for SNAP. Many of you may know it as food stamps. The program currently reaches 43 million Americans. It is designed to help families afford food. About half of the people in this program are children. If you are in SNAP, you are on average receiving $136 per person per month. That's $1.40 per person per meal. The program is widely recognized as not being inadequate. And so included in the House version of the HEROES bill was a provision that would increase the overall size of the SNAP benefit by 15%. That's about $100 per person, per family of 4 in a month. And so it could make a real impact on families that are struggling to eat right now, which is a primary concern. But that has been stalled. Another key change to the safety net, which would make a difference, would be expanding Medicaid to all states which have not taken advantage of the ACA expansion. That's about 15 states right now. And people in those states, uninsurance rates are higher, and the states are not as well positioned to care for people that have COVID-19. But outside of the social safety net as it relates to health and well-being, we also have to think about what are some other areas where federal action is needed to meaningfully address these long-standing disparities. So one key one is there needs to be another fiscal stimulus. People need money right now to make ends meet, particularly because the last stimulus funds have dried up. There need to be concerted efforts to reabsorb workers into the workforce, particularly where there are these huge inequities between Blacks and whites. And as we think about, what are some of the key next steps? I'm not going to talk about everything on this slide in the interest of time, but I do want to focus on the bottom two. When it comes to identifying solutions to address obesity, COVID-19, and their intersection, framing matters a lot. And so how these policies are crafted, not from a legislative point of view, but how they're framed to the public can really impact support for what the public decides to get behind. And for these high profile issues, public support can matter a lot. So a lot of thought needs to go into how do we frame these issues around COVID-19, around obesity, to ensure that programs that stand to help people the most can actually get pushed forward. And then the second is that we really need a lot of research. There's been a flurry of scientific research that has tried to address pressing questions, particularly at the intersection that we're talking about today, but there's a lot of unknown. So for example, we don't know the answer to the question of, in the short term, if you can help people lose weight, if you can help people change their diet, can that lower inflammation and mitigate COVID risk and increase vaccine efficacy? Now, it's not the solution, as Dr. Strings pointed out, but could it help people in the short term? And we don't know the answer to that. So there's a lot that needs to happen. A lot has been done, but this is an area that is ripe for interest and focus because I think we can move it forward if we have the right amount of will. So let me stop there and invite Dr. Strings to join me on the stage.
Thank you. So I'd like to ask you a couple of questions since we have some time. One of the things I wanted to ask about was the question of obesity prevalence, as it's being defined as a BMI of 30 or greater. One thing that we notice is that Canada, for example, has obesity prevalence of approximately 30%. The United States, the obesity prevalence is approximately 36% for all populations. And yet they have had only approximately 10,000 deaths. So what we notice is that the obesity prevalence is, again, quite minor, the difference, the disparity. But the disparity in deaths is actually astronomical, right? However many, over 200,000 for the United States, approximately 10,000 for Canada. What do you think can explain that, given the very small disparities in obesity?
Yeah, it's a great question for which I don't think there's a perfect answer. My initial reaction is, number one, is that the reason people are dying from COVID-19 is not simply because they're obese. So that can't explain these broad differences that you highlighted between Canada and the United States. And I'd say the second is that, Canada certainly has inequities like we do here, but arguably we have much larger ones here. And what we're seeing is that all of these negative effects of COVID-19 are clustering. They are clustering among certain populations. And so these are populations that are less likely to seek care, less likely to get good care. And so I think what a lot of this comes down to is both people's access to the healthcare system, being if you're Black or brown, higher risk of exposure if you fall into that category. But then we can't forget that the government response in the US has been far from ideal. And so it's a reasonable thought exercise to ask the question, if the response had been swifter, if it had been stronger, would more people be alive? If I talked about that number of how many more Black Americans would be alive if there simply wasn't a Black-white disparity. But another reasonable question is, how many more Americans would still be alive if we'd had a better federal response? And it's a tough question to answer, but it's one that I think we have to grapple with as a country.
I believe now is the time in which we're going to turn to our student questions.
Yeah, so let me, if I may, welcome Montunrayo and Brent, and say that for those of you who are in the audience, please take this opportunity to put questions in the Q&A, and we would love to hear from you. But as a first step, I want to turn the mic over to Montunrayo, who, as Dr. Brown-Nagin announced, Dean Brown-Nagin announced, she's a doctoral student in health policy here at Harvard. And then after her, we'll go to Brent, who's a doctoral student in sociology at UC Irvine. So Montunrayo, let's go to you first.
Thank you so much, Dr. Bleich and Dr. Strings, for being here and sharing such pertinent information today. My question is, you both have made it quite clear that there is, some overlap with the folks who, Black folks who experience higher rates of obesity and also tend to be low income. And so my question is, given that there's a double whammy between folks who are low income and so tend to be more food insecure, and also tend to be more be more exposed to obesity, what is the role of public health in, how do we frame this? How do we tell people who are experiencing higher levels of food insecurity and who have to, think of how to feed their families, but how do we tell them that you might also need to cut down on calories? How do we frame this in a public health manner and also save lives?
Dr. Strings, do you want to take that first, then I'll go after you?
Sure. I think that's an excellent question, Montunrayo. And I think one of the things that I've seen in my own research is that when you are looking at the relationship between food security and health outcomes, especially when you're looking at things like diabetes, for example, what you will find is that the relationship between food security and chronic conditions is not attenuated by BMI. And so what this means is that we don't really need to worry about telling low-income individuals to lose weight. When we include BMI in our models, it actually doesn't have a very strong relationship to health outcomes if we are looking at these upstream factors like food insecurity. So I think that we don't have to worry about telling people who are marginally housed, marginally employed, barely able to access food, those individuals who are food insecure, we don't need to worry about telling them to eat less. We don't even really need to worry about telling them to eat healthy, because telling people to eat healthy is not enough to give them access to healthy foods. What we need to worry about are structural interventions that can actually give people the access to healthy foods, the access to clean drinking water, and the ability to move their bodies. And then once we've given them access, if we believe in liberty, we can simply leave them alone. We're not going to eradicate fatness. Fat people have a right to exist. And the real issue here is whether or not people have the access to the things they need to lead healthy lives.
So I'm gonna respectfully disagree a little bit with what Dr. Strings said. I think Monturayo, it's a really interesting question. I'm gonna say it back to make sure that I have it right. I think what you're asking is, for families that are struggling with food insecurity, how do we frame questions around obesity? Because those two things could potentially be at odds.
Right.
And my reaction to that is twofold. On the one hand, I agree with Dr. Strings that waving your hand at someone and asking them to change their behavior is not a sustainable way to promote reducing your weight and bringing you to a healthier place. That said, I think that there is a role for education and there is a role for changing the environment. So let's talk about the environment first. It is widely accepted, if you talk to people in academic circles, that what is driving obesity is not the choices that you and I are making, it is the broader environment that is causing us to overeat and exercise too little. And so if there are ways to structurally change the way that we live so you can bring down barriers to healthy things like healthy food and raise up barriers to unhealthy things, then we are all better off. But at the same time, I think that we have to realize that people are making choices all the time. And so while those choices are very much scripted by our environment, I think that there is often misunderstandings about the relationship between what we eat and how it affects our lives, and are there changes people can make that could help them at the margins? And I think the answer to that is yes. And one reason why I think this is so important, why education has to play a role, is currently 1 out of 2 Black people are obese. If someone has an elevated BMI, meaning their body mass index is high, there are mountains of evidence which suggest that having a higher BMI increases your risk for all sorts of health conditions. So we can't wag our fingers at people and say, you need to do things differently. But the challenge is, it is statistically normal in this country to be heavy. And so I think what we have to do is, it's a both and. We have to harmonize education with these structural changes and not rely on one over the other, but recognize that if there are areas where there's not good public understanding, you can make an inroad there. And at the same time, you have to change these environments so that the default is the healthier choice and you're not setting people up to fail. I hope we answered your questions, Monturayo.
You did. Thank you both so much.
And Brent, perhaps we could turn to you.
So my question is, in light of what we've heard so far, what role can academics, public officials, advocates play in kind of continuing this process of moving our understanding of issues like COVID from the individual level, where we're only focused on individual choices and what someone should or shouldn't do, to more of the structural level, where we're actually looking at what governments, what institutions, and what, groups with the power and authority in society can do to make a situation like the current pandemic easier on the everyday individual who's trying to still put food on their table while avoiding getting sick and handling other responsibilities. I'm wondering how academics and advocates can kind of continue to shift our understanding of these issues up towards more of a structural level and away from any one individual's choices.
Dr. Strings, do you want to take that question? How can we shift the conversation to a structural level?
Yes, I think one of the things that we have to consider is that when people talk about the burden of obesity, especially the financial burden, what they are referencing is the cost of treatment of Americans given our outlandish insurance system. If we were to instead focus our energies and invest our money in trying to improve the environment in which people are living, we would find that it would be far less expensive to ensure all Americans, to provide healthcare to all Americans in ways that can actually address the kinds of disparities that we're seeing in health outcomes with COVID, as well as with other illnesses. And so when we're talking about how academics can shift the discourse, what we need to think about as researchers is moving away from the kinds of what I once heard someone call brute descriptive statistics that show simple relationships between weight and a health outcome that nevertheless cannot lead us to causal inference. That is, we cannot assume causation. We can only see that these things are connected. And to the extent that we understand that there are upstream factors that are contributing to weight gain, we can see that these things are connected largely because of social and structural factors that are driving poor health outcomes. So if we are truly interested in addressing these as academics, we need to move beyond these kinds of questions of what kinds of things are correlated, and instead look at what are the histories and legacies and practices that we need to address and we need to change. Part of what I was talking about at the outset is that we have a history and legacy of treating Black Americans like we are only able to have access to bare life at that, and by treating us in the medical field like our tissues should be extracted, but our biography should be excluded. We need to move to a whole person approach. And part of that would include efforts by academics to think about histories, legacies, and also to make policy interventions, or at the very least do research that can contribute to policy interventions that would change our system of insurance that we have right now to a single payer system that would be far more cost effective and give better care to everyone.
Thanks, Dr. Strings. And let me try to give a different thought on that question, Brent. So what I would say is if someone is in a position to make policy, let's say at the federal level or at the state and local level, there's sort of three core questions that they need answered for a given type of intervention, be it structural or not. How much is it going to cost? What are the benefits? And how many people is it going to touch? And I think so often there are these big, important questions that matter a lot in policymaking circles, which are not considered in academic research. And I think that the key is if you're in applied fields that have the potential to add to the policy discourse, you have to ask the right question. In academia, we are always pushed to, do you have the right question? But it's not really, do you have the right practical question that's going to matter in policy circles? It's more of an academic exercise. And I think we have to discipline ourselves to ask not just every important question, but ask the urgent questions that really matter the most right now. And it is without a doubt that if we want to meaningfully change these huge disparities that we've described during this show, we're going to have to make structural changes. But in order to push that process forward, the role of academics is to bring the evidence to bear that can contribute to the conversation and hopefully help to move it along in a meaningful way.
Thank you.
I hope that answers your question. And now we would love to turn to you as the audience. Thank you for the questions that have come in. Please keep them coming. We're going to go ahead and get started. And Dr. Strings, perhaps you can do the first one, and then
yes,
I'll
absolutely.
talk to you.
So I think it would be okay if I ask you the question, perhaps you can answer. And then if there's time, I can also respond. So there is a question here, which is, what is the importance of racial representation in clinical trials for medicines and other treatments? And then second part of that question, what is the impact of weight stigma on health outcomes, especially as it intersects with racial stigma?
How about I take the second one and you take the first one?
Fair enough.
So on the issue of weight stigma and racial stigma and how that interacts with health outcomes, it's a great question. And I'm not going to be able to give a really short answer, so I'll try to give an abbreviated answer, and I'm happy to follow up afterwards. You know, weight stigma and racial stigma, the reason why they matter a lot when it comes to the treatment and prevention of obesity is both those things can discourage people from going to the doctor. So someone may have obesity and choose not to seek care because they are embarrassed by it and they feel as if they're going to get stigmatized. Someone who is Black or brown may choose not to go to the doctor to get care because they feel as if they're going to get discriminated against. And so what those things add up to is unmet need when it comes to care. And then if that happens and diseases are progressing, which can then place you at higher risk for something like COVID-19, then you have this constellation of factors that puts you at higher risk and makes you more susceptible to disease. And so I think the way to think about it is anything that is keeping someone from getting the care that they need and is putting them at higher risk is particularly problematic right now, because it is that higher risk profile that is causing a lot of the higher infection that we're seeing right now. And Dr. Strings, do you want to take the first half?
Yes, and I'll also say something about the second half as well. So just to think about the question of the importance of racial representation in studies, we have to keep in mind that race is not biological. So that's very important. But it does not mean that there are not ethnic differences that contribute to health outcomes. And so what we find is that sometimes biomarkers that are created using what's considered clinical practice guidelines based on evidence-based medicine that incorporate almost exclusively white populations. I was speaking to this at the outset. To the extent that white populations might have different clinical thresholds as has been shown in many different studies, than people of color, right? And even amongst people of color, there will be distinctions. We cannot rely on the thresholds initiated through evidence-based medicine on white populations to understand what might be best for populations of color, because there could be ethnic differences in these clinical thresholds. And these are not being represented in clinical practice guidelines. There are a number of medical sociologists who have described this problem, including people like Steve Epstein and Stephen Timmermans, who are at Northwestern and UCLA respectively. So we need to think about how important it is to include people of color in this research and of course in the clinical trials, if we want the treatments that are developed to be relevant to all populations. So that's first. Secondly, when we're thinking about the impact of weight stigma, we have to understand that part of what's happening is that people are being told that they are obese and they need to lose weight, and that this in and of itself is contributing to worse health outcomes for fat persons. It is far healthier for a person to stay fat than it is for them to go through the kind of inevitable weight cycling that results from telling people that they have to lose weight, and the reality that losing weight and keeping it off is extremely difficult to do. If it were good advice to tell people to lose weight, then we would notice that we would not be in an obesity epidemic right now, because we have been telling people since 1999, when the first CDC report was released, the spread of obesity in the United States, to lose weight. In the subsequent 20 years, we can see that nothing has changed. It's because this does not work. And even if we were to be able to get people to lose weight, that would in no way address the myriad structural factors that are contributing to poor health outcomes, which was the purpose of me comparing the United States to Canada. We have similar rates of obesity, wildly divergent rates of COVID mortalities. We can understand that weight is not the issue, structural factors are.
So I just want to give one quick reaction, and then I want to toss you a question from the audience. And I would just say that if I put my public health hat on and we think about just obesity in its own lane and not the intersection with COVID-19, there is a lot of evidence which suggests that if a person loses weight, they will experience a lot of beneficial health outcomes. I think the point that Dr. Strings is underlining is that weight loss is really hard, and sustainable weight loss is even harder. But I would say that it is something that is so important for health in the long term, that people are at a weight that is not straining their heart and putting them at higher risk for other diseases. But I agree with the point that just losing weight is not going to solve the problem of COVID-19 that we're in right now. And so let me, if I may, toss another question at you. And so I'm just going to read it. And it says, I would argue that modern racism has done even greater harm than slavery. And modern racism is not simply a legacy of slavery. Today, for example, about a third of business profits derive from paying lower wages to workers of color. This is the powerful root of modern racism. Dr. Strings, what is the reason for your focusing on slavery and not contemporary systemic racism as a cause of the deadly disparities in COVID-19 illness and death?
Thank you for that, Dr. Bleich. Yes, I am not clear as to the argument that modern racism is separate from slavery. Modern racism is part of the legacy of slavery. We need to understand that racism cropped up, specifically the idea of race cropped up as a mechanism of justifying enslavement. So many people may be unaware of that. When we think about the origins of race science, it was developed in the 17th century by a man who was a Frenchman named Francois Bernier, who was trying to intervene into questions of whether or not there should be natural slaves. Thereafter, in the next 200 years, there were different Europeans who were creating ideas about race as they attempted to justify the ongoing enslavement of Black Americans. And therefore, when we talk about racism, we must talk about slavery. It is part of the legacy of slavery, such that even when we see contemporary forms of racism that are playing out, for example, in the business field, it is not separate from that history. Nothing is separate from that history. History is the present. It's what we're dealing with right now. And so, sure, those kinds of racism are consequential to Black people who are living in current times, but they're part of a continuation of relationships between European Americans and people of color, and especially for today's conversation, Black people, that lead to worse outcomes in terms of health and also in terms of general life satisfaction and economic security.
Thank you, Dr. Strings. Maybe as you're looking for the next question, I can take one that I see in the chat that has come up a number of times, which is around the measure of BMI itself, which is body mass index, and whether or not we can rely on it. So let me try to tackle that one. So the way that we just determine if someone is in the obese category is we take their weight in kilograms over their height in meters squared. And so there's a lot, and then that if your BMI is above 30, then you're considered to have obesity. If you're between 25 and 30, you're considered to have overweight. And I think the point that is being raised in the chat, the implicit point, is that it's an imperfect measure, and that's exactly right. And so if you take pretty much any professional football player or basketball player in this country, they would probably be classified in the obese category, because the key thing that the measure does not do is it doesn't account for muscle mass, for example, which matters a lot when we think about someone's health, their muscle in relationship to their fat. But what do we know about BMI? There have been dozens of hundreds, if not thousands of studies which have looked at the relationship between BMI and all sorts of other health risks, heart disease, diabetes, hypertension. What's very clear from all that research is that as a person's BMI goes up, so too does their risk of all these different health adverse health effects. And so it is not a perfect measure. It is widely acknowledged not to be a perfect measure, but it does give us a good sense of risk in a population. And importantly, it's a very inexpensive measure to collect, because either you're physically putting someone on a scale and measuring their height and weight, or you're asking them over the phone their height and weight. And so you can get large amounts of population data at a low price, whereas other metrics, which might add more precision, would really increase the cost, which would, as a result, greatly reduce the sample size. Dr. Strings.
Yeah. So thank you for that. And I would like to respectfully disagree. I do find that one of the major problems with BMI is that it was created by a man named Ancel Keys, and it was done directly as a result of the existing categories of weights as they supposedly related to health, which were the standardized insurance weight tables. What he said when he developed these BMI categories was, this is arbitrary, but it's no less arbitrary than the weight standards that we inherited from insurance companies. Actually, each of these moments is problematic. Why should we rely on arbitrary measures in order to be able to determine the relationship between weight and health? To the extent that there were any studies, we have no evidence whatsoever as to who was contained in them or what exactly these studies that led to the creation of these BMI categories. We have no idea who was in them or what those studies showed. All that we have are studies that have been conducted subsequently, which are the studies that Professor Bleich was referring to, that have shown correlations, yet again, between weight, BMI, and health. Now, the other thing I want to point to is that to the extent that this was apparently invented by some guy and may have not even relied on evidence-based medicine at all, that's a serious problem. But if it did rely on evidence-based medicine in which Black people were not in the studies, it's a different problem. It makes it now racist in and of itself. We do not get to have racially exclusive measures being applied to the entire globe. We can understand exactly how problematic that is because, again, the clinical markers for different ethnic groups may vary. And therefore, we cannot use standards created by white populations for people of color. This is one of the major problems with BMI. That, and of course, the fact that the many subsequent studies that have been conducted, many have shown correlations between BMI and comorbidities. Many have shown that those do not exist. There is such a tremendous conflict within the medical literature surrounding the validity and the utility of BMI that in reality, we can take a holistic approach to health outcomes that does not rely on weight classes.
So I'll just put one footnote on that, and then I want to toss you another question, Dr. Strings, from the chat, which is to say that I think there's some agreement that BMI is imperfect for all groups. And there has been an alternative measure that was developed, for example, for Asians, because typically they tend to be shorter, they tend to be smaller stature. And so the BMI that's used in most places has not been as applicable. So I think there's been some thought to just say, how do we make this measure a little bit more appropriate to different populations? But I think your point is that more could be done to make it more applicable across a more diverse group of people. And I want to raise a question that came up in the chat, and I'm guessing you'll have a good answer for this, which is during the course of this conversation, we've raised this question of how do we think about meaningfully changing structural inequalities? And so some of the folks listening would love to hear your thoughts on how we would actually go about doing that, either through policies or practice.
Sure, absolutely. I'll be happy to answer that question and then also turn it over to you for your responses as well. I think there's a lot of things that we need to think about. One of the things I talked about already was the question of single-payer healthcare. To the extent that our health insurance is wildly expensive for absolutely no reason other than to contribute to the profits of insurance companies, if we were to move away from an insurance-based model to a single-payer model, we can already reduce dramatically the outlay on health expenses. So much of the conversation surrounding obesity is that obesity is expensive, but it's not true that obesity is expensive. It's true, however, that healthcare in the United States is expensive. It doesn't matter your weight. So if we get to a single payer system, this will dramatically reduce costs. The other thing I want to mention is that we can spend some of the upwards of $70 billion that Americans put into weight loss, and $8 billion of that, which is specific to the medical field, we can transition all of that money and all of that energy to creating infrastructure for people who need assistance. When we think about things such as our current welfare state, we notice that many people who need paycheck assistance, many people who need assistance with groceries do not get it. And instead of putting money into trying to figure out how to make people lose weight, we can put money into helping people. Very simple. Help them get access to fresh fruits and vegetables. Help them get access to clean drinking water. Help them to get access to healthcare. All of those things would have a dramatic improvement in the lives of many Americans. And the final thing I want to say on this is that, and I've mentioned this already, we need to remember that fat people have a right to exist. They can be healthy at any size, but there's a way in which health starts to be its own form of moralism. We don't need to tell people how to change their bodies. We can allow them to simply exist. And I think it's very interesting that here we are, two relatively slender Black women who are discussing whether or not we should let people exist in their own bodies. That speaks to the thin privilege that we have as researchers. And this is another thing that needs to be addressed. The people who are commonly being called upon to speak on these issues are people who do not live in these bodies. It just so happens that I came to this topic because I was researching thin studies, as many people know. The original title of my book was Thin, White, and Sage. And now that I am effectively a fat studies scholar, I find that I am called upon to speak about issues that are not relevant to my life. So we need to consider the fact that fat people have a voice, they have a right to exist, and it is their choice whether or not they want to follow the dictates of health that are being currently instituted in the medical establishment.
And so I'll take a little bit of a different approach to answer this question on what do we do to try to address structural inequalities. And from where I sit, I think that where there's real immediate opportunity is thinking about the fact that we have, although imperfect, we have a large social safety net in this program, in this country, that is meant to provide food. It is meant to provide nutrition assistance. It is meant to provide housing. It is meant to provide health insurance. And it does some of those things okay. It does some of those things poorly. And there are a lot of opportunities right now where these programs could be strengthened and enhanced and enlarged in ways that will really meaningfully impact people's lives. The way that I sort of approach all these different topics is, how do you, given the current political climate, given the realities of politics, how do you shove through policies in these very discrete windows of opportunity that have the opportunity to really impact lots of people, but do it in a feasible way? And so I think that the incremental approach, which is sort of what I'm advocating for, thinking about how do you strengthen SNAP? How do you strengthen the school lunch program? How do you strengthen housing? How do you expand Medicaid? How do you take existing social programs and make them stronger? And by doing so, leverage the existing networks that exist. And I think in the short term, that's going to be one of the fastest ways to get help to people that are suffering disproportionately because of COVID-19.
Here's a question. Do you think our culture is fat phobic? Should that be a systemic issue we look to dismantle?
So I think that as someone who studies obesity, I really try hard not to use the word fat because I'm concerned about the weight stigma associated with it. I think that broadly in this country, we have a huge problem with weight stigma. And I think one of the real challenges is that when there are news reports about obesity, and again, statistically, it is now 1 in 3 adults. It is 1 in 5 children. It is expected to be much more than that in 10 years. But statistically, when you see obesity on the news and it's being called up as an issue, what you tend to get visuals of is morbid obesity. And it's very easy for someone to dismiss that and say, that's not me, I don't have a problem. And from the public health standpoint where I sit, I worry about that because A, it's shaming people and it's making people feel as if they might not want to seek care. But more importantly, I'll go back to this point around risk, is that as someone's weight is going up, so too is their risk. And what you want is for people to have healthy lives while they're alive and to die at an older age. And if someone has obesity, they are both increasing the poor quality of life while they're alive, and they're increasing the chance they're going to have an early death. And so I think weight stigma is a huge issue, which is being tackled from a lot of angles. But I think there's a bigger concern about how do we prevent obesity onset, because once a person starts gaining weight, it is so hard to get them to reverse that. Dr. Strings, do you have any closing remarks, or do you want to take a stab at that question?
Sure, I'll just offer a few comments. When we're talking about fat phobia, we don't get to pretend that it exists outside of the medical field. Fat phobia also exists within the medical field. It's the kind of thing that prevents people who are fat from going and seeking care. And it can even prevent sometimes people who are considered normal weight from seeking care. I personally have experienced within the past couple of years going to a doctor, having them see that I had gained 4 pounds and having the doctor tell me to keep my weight down. Think about the absurdity of that. Here I am, a person who is within the normal weight range by their own standards, but a simple weight gain of 4 pounds leads to a certain type of terror. Oh, we got to make sure that we keep thin people thin and make fat people thin, right? So this has negative ramifications for all of us. It means that instead of focusing on eating healthy, exercising, leading healthy lives that are enjoyable, we must constantly be afraid of the disciplining of the medical field about our bodies and shaming surrounding our bodies, because inevitably that's what us also facing. And it's worse for people who are identified as obese. If we want to help people, what we can do is move away from these kinds of medicalization of fatness that lead to the notion that it is a disease to be a particular weight. And we need to instead focus on how do we provide people with the resources that they can use to lead healthy lives without shaming them.
Thank you, Dr. Strings. We are just about at time, so I want to stop us here in terms of the questions, and thank you all for all those interesting and provocative questions. I also want to thank Dean Brown-Nagin for hosting this event, and a big thanks to Radcliffe for making this possible. Also to Dr. Strings, who wrote the op-ed that launched this conversation in the first place, and to Motun Rayo and Brent, who came and asked those interesting questions. Please have a look at the Radcliffe website for future events related to the legacy of slavery or just Radcliffe programming in general. It's been a real pleasure to spend time with you all this afternoon, and I hope that you all stay well.